What kind of clinical education curriculum, including simulation, do we need in order for the student to progress in these abilities, or in order for the nurse, the clinician, to progress in these abilities? How do we teach this sense of salience, knowing what's relevant in clinical situations? And how do we assess that competence in the end? Now, one of the issues I failed to mention about assessment, I just want to bring up, the issue of task specificity is a problem in being able to get a general measure of clinical reasoning ability, because it's how one does on any particular task is dependent on what they know and the kind of experience they've had with that particular scenario. So we found in studies on assessment of clinical reasoning that there's very little intercorrelation among different tests of clinical reasoning ability because of this content or task specificity. Well, that says to me, if we're going to assess competence around clinical reasoning, that we need to test students on a range of tasks. We need to have a range of scenarios that are representative of the kind of problems, the kind of clinical scenarios that the clinicians need to be able to respond to, need to be able to manage. So we really need to be clear, I think, and I think we'll hear more about this tomorrow, about having tests of competence around clinical reasoning that have a representative sample of the kind of clinical issues that our clinicians, nurses, physicians, and others need to be able to recognize, know what's going on, and respond to. So that's, I think, having some boundaries around how do we describe that task? How do we categorize that scenario? How do we know what components of the scenario need to be there? One of my colleagues, Stephanie Sedaris, is doing some interesting work around complexity. How do we know that a scenario is more or less complex, that a beginner is more or less able to tackle this kind of scenario? And I think for us to have really good measurement of assessment, we need to tackle questions like what makes this complex. So in the end, we do need to know, are we having an impact? Simulation is a fantastic innovation and has great potential, I think, for helping students develop the habits of thought related to clinical judgment. And I congratulate you on the enormous and fantastic work that you're doing in this field. It's more than impressive, the kind of presentations going on here, the scope and the depth of the work, the quality of the work that's just grown exponentially in the last decade. And I congratulate all of you on this fine work, and thank you so much for having me here.
Okay, so we have time for questions for Chris. If there are questions in the audience, please step forward to a microphone. Any questions? Yes, please. They're in the middle of the aisles. There's one over here. Yes, please, at the mic on your left.
Thank you for the lecture. I just had a question on, I guess, different graduated levels of teaching in medical school, or at least what I was told was that it's fundamentally inefficient, so that it gives time for the third or fourth year medical student to read on their patients. So if they're spending half of their time not actively doing something, is that necessarily a bad thing? And then trying to inspire them to continue to read instead of, I don't know, going and taking fishing lessons or something.
So the question about during the downtime, I guess, in our clinical work, encouraging students to read on their patients. Absolutely, I think that's what it is, bringing to bear that knowledge from books or other sources to the particular patient situation, that they begin to develop some deeper understanding of that should be encouraged. And nursing, one of the main pedagogies in clinical nursing education is in fact preparation for clinical, with the expectation that the students will understand, seek out knowledge about the patients that they intend to care for the next day, that preparation is critical. It's part of, going into a clinical scenario in the absence of knowledge. You simply can't see what's in front of you. So having read that, having some understanding of the diagnoses, having some understanding of the patient problems that are in front of them is really an excellent use of the time. I don't see it as inefficient. It's kind of essential to the work.
Mm-hmm.
All right, next.
Bossa Murray from Penn State University up in Hershey, which they call the sweetest place on earth. Towards the end of your talk, you gave a whole nice list of questions on how one can think and questions that haven't been answered about designing a scenario. Now, I'm sure you thought about this tremendously. Can you give us some idea of how you have been starting to think about answering some of those questions?
Okay, so the questions about designing a scenario, about pre-briefing students, is that, I can't see where the question, oh, right there. It's looking for you in the wrong place. So I think when you part of the issue around creating a scenario, let's just start with a scenario that's going to trigger some kind of reasoning. So we set up the situation where the students get, they know that the area of the scenario will be, say, a patient on a medical unit who's got these 3 diagnoses, okay? And in the set up the pre-brief, the students get further information about the patient, much like what they would get in an end-of-shift report. So it's a setup very much like what they'd have. They also brief on the roles that they'll play as part of the team in the simulation, so it's clear what each of them are expected to do. And for beginning students, they'll get a greater detail about what they need to be thinking about with respect to the patient's problem, so that they're pretty well set up. We really want to find the kind of scenario that's challenging but doable as kind of a guideline for these students. And Stephanie Sedaris again in our center in Ashland, Oregon, is doing a lot of work in pre-briefing and thinking through how to help set up students so that they get into a situation and really have a good understanding of that. A great deal more work is needed in that area, I think, of creating a debriefing or a pre-briefing approach to do that. The scenario itself, consideration has to be given to what constitutes complexity to have a scenario that will be challenging enough that the student has to reach for it, that it's not blatantly apparent, but not so difficult. So thinking, for example, about the kind of cues that are presented and how subtle they are, and having the simulation specialist be prepared to do a rescue if the student ends up going down the wrong path, so that we have enough experience with many of the scenarios that we know the kind of path that the students may take, and at what point we need to bring in the nursing supervisor who might kind of redirect the students so they don't end up in a blind alley or doing something that may cause harm, so that we get some coaching along the way when in fact the scenario is much too challenging. I think Mary Cato and Paula Gubert-Howe and Stephanie Sedaris each are doing sessions during the day that will help kind of call attention more to the kind of scenarios that help support that.
All right, move on to the next question.
Yeah.
Here on my right, yes.
Yes, thank you.
Hi, I'm from the University of Alabama, and I have a question about the pre-briefing and concept-based learning.
Mm-hmm.
So I guess my understanding, and maybe you can help fill in the gaps here, is that you would have them come into the pre-briefing with a basic concept map, do the simulation, and then in post-briefing or debriefing, you would fill out the gaps that they had on that concept map? Is that how you use it?
That's actually not what I intended, but I think that's a fabulous idea. In fact,
Well, don't take it then.
Yeah, go for it. Excellent. Now let's hear about it next year then. You know, there's a lot of evidence supporting use of concept maps, and both in medicine and nursing, as a way to really build out and extend that kind of knowledge. My comment about concept-based learning activities actually had to do with what we do in actual patient situations, where we may do rounds on patients, see a group of patients. For example, students might accompany the clinical nurse specialist who's on the comfort team in the hospital and see 15, 20 patients during a day who are experiencing pain, and work with this clinical nurse specialist to really begin to understand the various patterns of pain expression and ways that we manage pain under different circumstances. And so they get to see multiple examples of this concepts related to pain and pain management. So it's actually a clinical activity that serves to deepen their understanding and their capacity for pattern recognition. And then thinking about the kinds of clinical situations or the clinical problems that we want students to be able to get that sort of depth of understanding so they can begin to recognize when something's not as it should be and engage in their clinical reasoning. But I like your idea of concept maps as a pre-brief notion.
We're getting close to the end of our time, so I think we'll take one more question, and then others feel free to come up and ask your questions after we've finished the session. So,
Dr. Malone?
Hi, Chris. My name is Beverly Malone. I'm with the National League for Nursing, and I appreciate your presentation. It's always nice to remember I can learn something. Sometimes I forget it, you know? So it's a good knock over the head that I learned so much by listening to you this morning. But my question is, I was delighted to hear you talk about physicians, about nurses, about occupational health therapists, but I know it's a bigger world of disciplines than that. And I'm wondering, how do we bring it to our colleagues that everyone feels included in this thing called the delivery of patient care and clinical services, so it doesn't still feel like we're leaving some folks out of the picture? You know, I know there are pharmacists that are really involved, and I know that there are physiotherapists who are really involved. So I know that there are whole cadres of other folks who are very involved, and they need to hear their names out loud. And I just don't know how we go about doing it.
Yes, thank you for that comment, Bev. And I think it brings into the foreground now this whole question about interprofessional collaboration, interprofessional teamwork. It's everywhere in every single report for the last 10 years out of IOM and every other study group. And clearly a part of that is assuring that the disciplines that work with our patients are included and that we're able to have meaningful clinical conversations across disciplines. You know, each of us really brings something different to the situation, so that whole business of how we engage in reasoning is going to be triggered possibly by different aspects of what's going on with the patient. That a social worker will see something very different than a physical therapist and an occupational therapist, which is why we need to bring each of us to the table, and we need to understand how it is that we can help each other understand the clinical perspective brought by that discipline. I know there's been a fair amount of work in that, what goes on in the conversation between doctors and nurses, and where those breakdowns occur in trying to help one another have the same clinical understanding so that we can join on the same path together. But we need to have similar kinds of studies and conversations with other disciplines, to be sure. Thank you.
thank you, Chris.